right, hello, heads. Welcome and thank you for checking into this dose of the Healthcare Uprising. I'm your producer in the back, Jeremy Carr, here with your host in the front row, Heather Pierce. So what's on our agenda for today, Heather?
Well, I'm going to keep this intro pretty short because Michael Perry, CRNA and an APRN, is on the show with us today with the Comprehensive Pain Center in Omaha, Nebraska. He goes into a very detailed background of his experience, his qualifications, and basically why he is such a rock star pain management specialist. So I'm going to leave that to the interview itself. So that's all I'm telling you.
So without further ado, here's Mr. Michael Perry, the pain specialist.
Hi, and welcome to the Healthcare Uprising podcast. Today we have Michael Perry, a CRNA, APRN pain management specialist, with us on the show today. Welcome, Michael. Glad to have you.
Thank you very much. I appreciate being on the podcast today.
Great. Well, and so really quick summary. Michael came to us via Stacey Meade, who was one of our human story shows that dropped, was one of our bonus human story shows that dropped between episode 13 and 14, right, Jeremy?
12 and 13.
Sorry, 12 and 13. Jeremy always knows the numbers of the episodes, not me. And Stacey and her husband, Tom, whose story she was sharing in that episode about his condition with pain that was pretty horrible. You were his doctor, and so Stacey connected with us, and so now we're here bringing you back on, or you onto the show to share a little bit about who you are, your history, all the things. So
and see how that was done.
Yeah,
impressive story.
It is, and pain is a common problem. So, Michael, tell us a little bit about your history, your experience in pain management, kind of what you do today, and yeah, just brief summary. Give us all the good details.
All right, I'll try and make it short. I graduated from Creighton St. Joseph in 1978, Omaha, Nebraska. It was a big medical center, and I've been in practice now 47 years. And from like 1978 to I want to say 1982, 83, I really specialized in what they call regional anesthesia in the anesthesia world, meaning using needles and numbing medicines to block different parts of the body to suppress pain so that you didn't have to give as much for a general anesthetic, meaning inhalations and drugs and things like that. So back then it was kind of, I don't want to say unheard of, but very few people, even the physicians, were trained in this. And I was trained by the best. They were called the fathers of anesthesia. I was on a plane somewhere all the time, learning and going somewhere to develop these techniques. Early in my career, I've done over 30,000 or 33,000 anesthetics, and a lot of them I used what they call regional anesthesia. They were injected with local anesthetics in the parts of the body beforehand and sometimes afterwards to reduce pain. And many of my patients that in post-op or going into recovery had minimal pain or discomforts. They woke up quicker. They didn't have as much of the anesthetics or the IV solutions or the inhalation gases. So that was a real plus, because a lot of times the patients say, what's the big deal? And a lot of them didn't have the nausea and vomiting. So early 80s, pain management then hit the scene, meaning whether it be neurology, anesthesia. Anesthesia at that time took over and said, hey, we're going to take over this field. We're going to develop the techniques for treating chronic pain. So, because at that time they were treating like the spine, whether you're from the neck, mid back, low back, et cetera, and the rest of the body. So there was a lot of folks training and teaching in that time, from the mid 80s even into the early to mid 2000s. So in 1993, the American Society of Anesthesiology had their first board review, and I, as a CRNA, I attended both meetings. One was at Harvard with Carol Warfield, and the other one was in Kansas City with Dr. Steve Waldman and Dr. Ellen Winnie. These are all huge names. These are people big in the pain world. And even though I could not take their test, what I was there for was to assess my knowledge, my skills, and my ability and I was the only CRNA in the country that was at these two meetings. But it proved to me what I did know, what I didn't know, or what I needed to do to go further in my career. So from the late 80s on, I specialized in pain. And in 1993, I went full-time in pain, and I've been doing that ever since. So I have learned from the best. I have over 2,000 hours just in CEs, in pain, not anesthesia, just in pain. And in 1993, when they had the American Academy of Pain Management, which was the biggest pain organization, and it was multidisciplinary, I passed their boards in 1993, which I was just a handful in my field to do this. And I also served on numerous committees with that academy for many, many years. And I was also a program surveyor, so programs, hospitals, homes, dentistry, wanted to be specialized and have a special certification. I would go in over 3 days and assess their programs, and then they would go about being certified. And also I served on many boards and did a lot of national speaking, and then local speaking with pain management. And then also in my career as a CRNA with my own peers, my early years, I was touring quite a bit, specializing talking on pain because it was all new. So for the last 20 some years, I've been in private practice, just doing what I'm doing. And I treat head to foot, literally. And there are textbooks out there. There's probably over 500 physical conditions that people suffer from. And each and every one of those, there is the potential to treat with those. It's just a matter, can somebody train them to do that? So I'll stop at that, and you tell me where you want to go.
Wow. First of all, you've seen a thing or two. I one of the first questions I want to ask that was not planned, but now hearing about all of the very, I would say, diverse experiences that you've had over the course of your career, what have you seen change? Like, were the problems that people have today, did they exist back in the early 80s? Did they kind of exist on a smaller level, but are more now? Like, I think about, migraines, right? Super common, lower back pain because of like we sit, so much and work at desks. I'm curious to see what kind of changes you've seen in actual conditions over the last, almost 50 years.
That's an excellent question. And thinking about that, I don't think there was near as much of the physical conditions back then as there is today. And I say that with reservation. I think a lot today has to do with environment, inflammation, foods, etc., that contribute to a lot of pain conditions today that didn't necessarily exist back then. And also, I think that there was less awareness, meaning if it was out there, nobody knew, because when you went to your primary, which back then there wasn't NPs or there were PAs, but your family physician or a specialist just wrote it off saying, well, you got to live with it because that's all there is, because there was no research. There wasn't any particular type of treatments other than getting a shot of a steroid. In fact, I'll share a real quick story with you. This was in 1979. I was in Grand Island, Nebraska, and I covered a little community on the weekends, and this old family physician, he always called me boy. He pulled me into a back room and had a big syringe of steroid. And he said, boy, he says, put it right here. And I go, why? And he goes, well, he says, I've been treating patients for years. And he says, I didn't believe him, but now I do. So he says, put it in my hip. So anyway, that's how I could kind of say was my first experience. But he recognized that people suffered, but they really didn't have a whole lot to do. And over the years, anesthesia and a lot of specialties, whether it's rehab med, all of the specialties have contributed over the last 20 years, trying to develop and find newer techniques or procedures to help people in chronic pain. And we've come a long way in that part, but then there's been some counter stuff. For the first 20 years, like in the 90s to early 2000s, the literature was if you didn't give an opiate, you lost your license. Then after that, now
You didn't?
if you didn't, you were in trouble because everyone was to be on opiates.
No way.
Yeah, I had stacks of journals that documented all this. So then over the last 20 years, everything says, no, it's just contra. It's the opposite, saying, well, we can't because this and this. And so it's like, why is it good for 20 years and now it isn't for 20 years? So everyone has to kind of decide for themselves. But, it's like history. You don't want to repeat itself.
Mm-hmm.
But my point is that some patients that, depending on the chronicity of their condition, those opiates, and this was before testing, meaning they didn't do hair and saliva and urine and all that kind of stuff. You had a pretty good population that they would tell you, if I stay on this, I go from a 9 down to a 6 or maybe a 7. And the FDA says all you have to do is move 2 points. But for chronic pain patients, 2 points is huge.
Wow.
So the point is that if they got to that level and they just stayed there, they could function. They could actually function and get through life. And then when they start taking all this away, that's when you see all this behavior that, well, I'm going to go to something else, whether it's alcohol, dope, or whatever they want to do. That leads them to this is because the medical world is limited. And I think virtually throughout the United States, all the primaries, physicians and like NPs and PAs cannot hardly prescribe opiates. They have to go through a pain clinic. And now what the pain clinics are going through, or at least I'm seeing a trend, is that they're limiting how much they're prescribing opiates now. And reimbursement is now a huge factor with all this. Mm-hmm. So everything's kind of evolving again. And I was at a meeting in 2017, Las Vegas. They had the gal from Medicare from Washington that presented, and she showed a slide that said, this is how much we're paying all you folks in pain. And she goes, we're not going to pay it anymore in the future. She goes, things will be replaced just by medications, meaning whether it be you have a patent or something else. They said, we're not going to spend the money. And that's the honest to God truth. So that's when things kind of start changing over the last 8 years or so, and you're starting to see that trend is because the reimbursement, even at the pain clinics, now many of the things that these wonderful people do have to be pre-authorized, and if they're not pre-authorized, they can't treat the patients.
Oh, the prior authorizations.
That's right.
Which that's come up a few times on the show. Prior auths are like, makes everybody feel not great. Yeah.
Yeah, and the other thing is a lot of patients can't afford or they don't want to afford to pay for the treatments themselves. And again, there's no guarantee, even after they do the procedures, that they're going to get the results they're looking for. So right now, I kind of think things are kind of in a limbo for the pain clinics. And I feel for them because every one of these folks that are in these clinics, they're all trained. They're all very well trained, and they have certifications and licensings and boarding and stuff that they put the time in, that they devoted themselves to this field. And for those folks, I really feel for at this time. It's because it's going to be a struggle in the future for them to continue to keep the doors open.
And a lot, we do hear a lot about, and I, outside of my podcast, I actually, I work for a startup and I've worked in healthcare for a long time, and the reimbursement piece can make it really hard, even for specialists or PCPs, right? Especially when it comes to Medicaid and Medicare, where they're changing that. So it's like, that's a big part of their patient panels, right? Like in that funding or the reimbursement or essentially the financials that come through that can either, I don't know, help keep your doors open or not. So
no, they don't. In fact, a lot of the reimbursement, especially Medicaid, it's like we have to pay to take care of the patient.
Yeah.
I mean that.
Yeah.
The reimbursement is so low, it doesn't pay for the time that you spent with them. And to me, that's just, it's not acceptable.
That's not how it should work. Right. That's not, and you're about to retire, right? So like you're moving out of this space. So you're like, good luck, everybody. Oh, that's going to be rough.
Well, I just feel for them, and especially Medicare, because there's such a high population. There's so much that Medicare won't pay for. And then if you have an HMO, then everything's going to be pre-authorized. Yeah. And what happens to a lot of us is we wind up taking care of these folks and we don't get reimbursed. So we're just doing our job. I shouldn't say job. We're doing what we were trained to do. We're trained to help people to get back into their life again. So a lot of times we're not compensated for it. And I just look at it this way. I'm just doing the work of the big guy up above. And as long as he was able to help keep my doors open and help me take care of my family, it's okay. I didn't have to make quote millions or, the almighty dollar, so to speak. But I feel for a lot of them in practice because this is what they're dealing with. And I'm 71, almost 72. I'm retired, partially retired.
Congratulations. I think well-deserved retirement.
Yeah, after all these years, I am missing not taking care of patients. I miss seeing when they come in, look at the emojis where they have the sad face.
Oh,
They
yeah.
come in, they spend an hour, that you hear their story, you hear the severity and pain and suffering. And then when they walk out, I call it that smiley emoji. And my analogy is that when they walk out of that office, it's like a little 5-year-old boy when he used to have candy stores and he came out with a little brown sack with every candy he wanted and he's smiling. And that's what was the payoff, or it's been the payoff in my practice.
Right. That's why people are in that, right? I mean, medical professionals are in it to take care of people. And what if I said, Jeremy, I always say, we want to let doctors doctor, right? And nurses nurse and PAs PA, right? All the things.
Yeah.
Yeah.
Not just make them do paperwork all the time.
Right.
Fight for the money they should be getting back from the insurances and stuff like that.
Yeah. So let's kind of, I want to make sure that we talk about Stacey and Tom and his story and his condition. And I want to hear a little bit about some of the more common treatments or common conditions that you treat. But first, let's talk a little bit about this trigeminal neuralgia. Did I say that right?
Yes, you did.
Woohoo!
Yep.
So that's Stacey Meade's episode. Tom, her husband, who she talked about on that show, that's what he was diagnosed with. He somehow made it into your office, thankfully, right? Because you got to hopefully put that big happy smiley face on his face eventually. Can you talk about what is that? Because that's like a really, I think, rare condition, I would say, or maybe I'm wrong there. So tell us about that. What is this exactly?
It's not rare, but it's not real common either. But and nobody knows the cause, and nobody knows why it happens. And I've been following the history on this and also treatments over the last 30 years. They use lasers, they do all kinds of things, and they try and get the trigeminal nerve, which is a deep nerve in the face. And I look at it totally different. And I've been doing this and treating this for over 20 some years, is that what I have found in my experience and in my hands is that it is superficial structures on the side of the head, the back of the head, the neck, and the face. And it's like an atlas. When I evaluate these people, I use what they call a Sharpie pin. It's just a felt tip pin, but yeah, the pain comes under the skin or the dermis. So like when you touch something or you see somebody touching the fire and bring their hand back, that sensation goes through what they call the dermis. So for lay people, that means that's a superficial layer. And that's where the sensory begins. So pain begins there. And what happens is, what I find is that there becomes scarring or adhesions, bands, whatever you want to call it, between when you press on the skin on the side of the head, the face, it should be soft like butter and you should be able to push. But with this pin, if it elicits the inflammation and the adhesions of the pain, the patients will tell you 100% of the time, you're sticking me with a needle. That's the sensation. Now, on normal tissues, it's just pressure. So that pin is my diagnostic tool, believe it or not. But as also, when I say an atlas, I'm talking about in the temple area, over the facial, the mandibular, the maxillary. All of these are areas on the face, and they're superficial to deep. Then in the front of the ear, it's called the auricular. And then in the back of the ear, there's a crease, and that's called the posterior auricular. And then on the side of the head, between the ear, those are called the auriculars or auricular temporals. So you map these things out when you do it, and then in the back of the neck, it's the third occipital and the lesser occipital. And then there's what they call some trigger points in the neck, which are the sternocleidomastoid and the trap. All that means that there's some big muscles on the back of the neck and shoulder. So all of these are involved, and it's usually about 15 or 17 points. And Jeremy, I think I heard when you on a podcast with Tom Meade's wife that, oh, God, that's got to hurt, those needles. Oh. Well, I tell you, the pain that they go through, because sometimes it's like electricity, it can be fire, it can be out of nowhere that these people have it. And statistically, within 2 years, a lot of them commit suicide.
That's right. That's called the suicide condition, or what's the name?
It's one of them. Yeah.
Okay.
Shingle and post-herpetic neuralgia can be one too, and I'll get into that one in a little bit. But Jeremy, to address when you said, "Oh my God, this is going to be terrible," all these needles in the face. It's not. It's a very small gauge needle. It's 25 gauge, and you have to remember the pain they come in. If they're an 8 or a 10, meaning they're going out of their mind, they don't even know what I'm doing, because as I take that needle and I use the solutions, and the solutions are made up of sodium chloride, 0.9%, and some 1% lidocaine, and I do mix
for numbing.
Well, it's not for numbing.
Oh.
I'll get to that here in a second.
Okay.
But it's like WD-40. It took me a long time to figure out the ratio between lidocaine and saline. And then if you mix in a little bit of steroid, then that steroid, let's say I got 20 cc's of solution in a syringe. So when I mix that 1 cc of steroid, that mixes so they become nanoparticles. So instead of sticking a big dose of steroid summon in the body and it lasts for a few weeks or a month, this stuff that as I'm injecting with the needle and breaking these tissues up with the needle and using the fluids, I always, my analogy is that the needle is the plow truck and the fluids are the plow. So instead of taking a dry needle and cutting through something and go through, from point A to point B from one level to another, and then you inject, I don't. As I'm slowly advancing, I'm using the fluids forcing to separate and blow tissues apart that allows the needle to go through without causing more destruction. But it's breaking up these bands, adhesions, whatever you want to call it. And by doing that, then blood can rush in. So the lidocaine is to make sure those vessels stay open. Like in surgery, when you do a regional block, meaning you numb something, you want it to heal afterwards. So you want those vessels to stay open. So what happens is that lidocaine, if it can keep them open for a few hours and it stays open, then what happens is that blood, when that comes in, they proved a few years ago that the immune cells, they're called phagocyte type 2. You can look all this up. It's the type.
We're going to need to do some research after this and have a vocabulary.
Okay. And if it sounds too medical, just say shut up and get into.
Oh no,
no, this is great. I mean, this is what it is. It's yeah.
But you can see the blood rush in immediately. So it's these immune cells over time, they will dissolve them. And for example, not just in trigeminal, but when I treat females, especially head and neck, where you get into deeper tissues, the toxicity will show up in their urine. And what I'm saying is that after they're treated, within the first 24 to 36 hours, the gals will look, say it's like a UTI. There'll be smell, sediment, different color. And sometimes it even looks like sand, but it proves what I've been doing. So if they talk about evidence-based medicine, I got thousands of patients that'll tell you that when they go to the bathroom and pee, there's stuff that they've never seen before. So
after the treatment, that would happen?
Like when I treat the back of the head, neck, and shoulders on women for certain conditions, when you get into the deep structure, the body detoxes.
Oh.
In men, believe me, in men, you never hear it. You don't want to ask them. They all have a heart attack. You don't want to even ask them anything. All they want to do is get treated, get in, and get out.
Yeah.
But getting back to the trigeminal, once you hit all these spots, then it's a matter of healing. You look and by the clock, and I do mean this, by the time I do the last injection, it's 5 minutes by the clock, something good is going to happen or nothing. And by that meaning, they're going to say, oh my God, things are changing. And then you ought to see the look on their faces, because they've been so used to pain. It's just like having another arm or, another extremity or sort. And they're looking and they're in shock because they don't know how to respond. And then it's like, when's the other shoe going to drop? When's it going to come back? So it takes them a while. So to alleviate a lot of this, I spend a lot of time beforehand saying, this is what may happen. If it does, this is what you're going to experience. And I want to plant that in their mind so that when things are happening, that it now makes sense to them that, all right, he told me, instead of being in shock and saying, oh my God, I don't know how to respond, then they can kind of go with the flow or the program, so to speak. It's because I've already kind of pre-recorded in their head what they may experience, and when it's happening, then they can get more excited instead of being anxious.
So, sorry, Jeremy. In Tom's case, did he react pretty immediately, or?
You have to ask Tom that.
Okay.
All I can tell you, and then
wait, that's PHI. Sorry.
HIPAA, man, HIPAA.
HIPAA.
Yeah. So he can tell you, but I can tell you hypothetically that these patients, especially with trigeminal, they'll go through a number of treatments over the several weeks. They'll go at least twice a week because you have to attack this stuff. You have to keep trying to get more blood flow. And every time you treat them, it isn't always in the same spot. It's kind of like, do you guys have what's called Chuck E. Cheese for kids out there?
There's some in Phoenix.
They have a game called Whack-A-Mole.
Oh, yeah.
One on the head, and another one pops up. Well, I call it the Whack-A-Mole syndrome because you don't treat what's already healed. You start finding what's left. It's like playing cards. So when I'm looking at the head and the face, I'm looking what areas do I need to go to the next time when they come in and what's already starting to heal. And all this, over time, and then they keep a diary and they'll tell you. And when you look at it, it takes days to weeks, sometimes 2 or 3 months. But once you get them there, then they're pretty well controlled because it's reversed. Meaning you got all those superficial nerves that are feeding into the deep nerves, but therapy today is, kill it, kill the goose, kill that big nerve. But when they happen, they may be pain-free for a while, but then there's another syndrome that happens 6 months or later, and it comes back raging, and then you can't do anything because you've already destroyed something, or if that makes sense. And you can take all the pills you want, but think about it. How is the pill going to get through all these tissues? If everything is obstructed and it's all superficial to deep nerve structures that are affected and the blood vessels, how's the pill going to affect that? The pills can work only if there's no obstructions. And there's a big portion of patients that they can respond to the medications or to pharmaceuticals, but there's a larger part that can't because I call it the payload. The medicine can't get to the payload because there's no blood flow to it. You can adjust, shoot, squirt, snort, I don't care. But if it's blocked in the tissues where you need to get it, it goes to the brainstem. And it's just like alcohol or anything. It makes you feel good because it went to the brainstem. So that's how these people do get some relief, is because it's going to the brainstem. And then when it wears off, the pain signals are breaking through again. They're getting to the brain, if that makes sense.
It kind of reminds me, in my layman's point of view, it sounds almost like muscle cramps, where the muscle tenses up and you got to work it out and get the blood flowing through again for it to get back to normal. But with the nervous system instead of the muscular system, it sounds like cramps in the nervous system is what it sounds like, which actually sounds quite horrible when I think about it.
Yeah.
But I mean, that's kind of the process then. You have to like break it, get it, the blood flow and keep the vessels open enough so that it can start flowing right and functioning right? And that's kind of...
Well, yeah, because actually the muscles are in atrophy because there's virtually no blood flow. Now, this is what's amazing about the human body. Anything else in life, if it doesn't have nourishment, it just dries up, rots, and falls off the vine, so to speak. Well, we as humans don't. Oh, the other thing I want that I failed to mention, hyaluronic acid. The body produces it in like joints all over the body. And it's designed to protect. It's like a lubricant. It's designed to protect things. But when you have trauma or injury anywhere in the body, when it gets released, because it's an acid, this is what causes the swelling. This is what causes the inflammation in the tissues. And because it's an acid, if it leaks, now this is real important, if it leaks and touches the blood vessels or the blood flow going to that area, it will cause them to constrict, just like cautery is in surgery, where you zap something to stop it. So think about it. If you put a drop of acid on a blood vessel, it's going to constrict. So what happens from acute pain to chronic pain is that if that blood flow is cut off immediately, over the next days, weeks, and then months, you accumulate whatever leaked into these tissue planes. They now become sequestered and then they encapsulate. And now you have whatever you want to call it, bands, tissues, I don't care what it is, but it's non-viable stuff because there's no blood flow to it. Nerves cannot fire through this. That's your pain. So, with the muscles, a lot of times when if you see people with atrophy, meaning you got something that's shriveled up, literature and science, physiology will say, it's irreversible. It's not true. The key is if you use these kind of techniques, break these tissues up, get blood flow in. It's like turning on faucets. Once you get blood flow and they fill those muscles up and there's separation, so the nerves, they get the hydration, they get the electrolytes, they can now start firing again. And it's like not only did you put gas in the tank, but now you can turn the starter on. And that's how all this stuff works.
Wow. So trigeminal neuralgia, we definitely covered that. I feel like I just got a medical lesson on the body. So thank you for that. This is we're definitely meeting our goals of education in this show today. I like it. But let's talk a little bit more about and also before I jump into that, treating somebody with trigeminal neuralgia obviously is over time, right? Probably like most things. There isn't like a pill that solves something overnight or a treatment that solves something overnight. But we know there's a lot of other conditions that are very common, like migraines, lower back pain, shingles, things like that probably a lot of people that are listening have experienced. I mentioned my youngest. Yeah, my youngest son, he has migraines. I know so many people that get migraines. Shingles, obviously, getting closer to 50. So we're going to be, I feel like shingles is becoming more common than pregnancy in my life. Amongst my friends. So can you talk about how you treat conditions like that? Like maybe let's start with migraines because I feel like that's super common.
Migraines can, again, I want to reference like the whole body as an atlas. So example, if I open up an atlas of the head or the neck, I would have all these spots that I tell you about that I use the Sharpie. So everywhere you see a black dot is where you're going to treat. So like when I talked about on the trigeminal, it's the same, similar with migraines, or can be, is that you're going to look in the front of the head, depending on their presentation. If they have pain above the eyebrows, there's two nerves, two little tiny ones called supraorbital and supratrochlear. Nobody pays attention to these bad boys. And they can be part of it, but they're a very small part. But if you do, you use a very small needle, just go under the skin, and you separate the tissue. You do not want to hit the nerve because if you do, the eyelid will droop and you're in trouble. But in good hands, like mine, you just superficial, you feel a high resistance to a loss of resistance when you do these injections, and it happens immediately. Things will open up spontaneously, but you also look like in migraines in the tempo, the auricular tempo, meaning between the ears, the back of the head. The key ones are what I call the lesser occipital. That's what they call on the back of your head between the hard part and soft part. There's a little shallow opening called a mastoid. That's where that nerve sits. And then another one that's called a branch of the third occipital. That's the key one behind the eye. Now, migraine is more than just something behind the eye. It also, like in you gals, it involves the neck, the upper back, and shoulder areas, and some intercostals, meaning between the ribs along the scapula. When you count the ribs, they're like 1, 2, 3, 4, 5, 6. And you women, as Archie Bunker would say, it's T3, T5, and T6, that if you hit those, open those up, you hit the suprascapular notch, which is affects the arm going up or down. But believe it or not, it's tied into migraines as well.
Really?
Trigger point. Yeah, honestly, God, I'm talking thousands of patients and numerous videos.
I did not realize that. And I have numerous friends that have females who have pretty severe migraines, but they've never mentioned anything about the pain up here. But I've also never asked.
They might not think to connect it as.
I wonder.
They're so focused on their headache.
Yeah.
That the other is secondary. And the reason I can tell you that is once they treat it, all the areas, by the way, when I say these areas, you have to treat it like a map. You have to treat every one of them. Mm-hmm. You do not miss one of them, because if you don't get the full benefit. But they'll tell you, they'll raise that arm much easier. because you gals carry everything, like kids, purses, etc. So everything's in your neck and your shoulders, not men. Men is different. But what I'm saying is that in women, when you treat all of these at the same time, it's all part of a migraine. And the one that I call the third occipital off the side of the neck, that one goes behind the eye. It's 100%, not 99, not 95 or 80, 100% of the time. If it's injected right, if they see zigzags, spots, auras, I don't care what it is, that this stuff goes away in milliseconds. And then what happens is that once you get that pressure behind the eye or the aura gone, you still got to treat the rest of the headache because there's more to it than just that pain behind the eye. And neurology is doing imaging and MRIs. They're trying to figure out, what part of the brain. And I'm saying it's in the back of the neck. But you can talk about what they call cranial nerves. I talked to a few specialists and they try to theorize. But in my mind, it makes no sense. So something so shallow in the back of your neck, how can it affect your optic nerves and all the major structures in the back of the eye? All I know is that it's like the sun rises, in the east and sets in the west. I know when I do it. I know what I'm going to see. I can't explain it, but it's going to happen. So it's up to the science to figure out some of this stuff. But I can tell you these are part of the patterns that they need to look at. And when they do that, you have to do a series because it's the same thing, meaning they come in weekly for several weeks. And what you're looking for, again, what's healed, what's not healed? What else do I got to treat besides what I just treated?
And people that are coming to see somebody like you, like they're getting to the, with migraines, or we'll just keep on that. That's like pretty severe cases then, because at least I don't know anyone who's gone to pain management for their migraines. And now I'm wondering, should they, right? Like maybe it's just they don't know that they have that option.
Many of the pain clinics will do what they call a greater occipital nerve block, lesser occipital nerve block, or even the third occipital. And that's what they're limited. And they'll say, yeah, I got some really pretty good success. But the key is you got to get all the other areas. And that's what's missing in this puzzle, so to speak. Because I can guarantee you, I've had over 33,000 patient visits and thousands and thousands of migraine patients, especially women. And it's the same stuff. Meaning when I walk in, I know what I'm going to look at, I know what I'm going to see, I know what I'm going to find, and I know what's going to happen 10 minutes later. It's very rare that you see that it isn't complete. And a lot of these patients, even the nausea and vomiting goes away. Can I explain any of this? No, but I can tell you that it's reproducible. And to me, that's the key. And even if let's say they even come like once a month, but if they were having like 14 headaches a month, and now we're down to like 1 or 2 in the last 2 or 3 hours, what I'm looking for, what are the tissues that are building back up? And I'll jump in with this too. I think a lot of this with the migraines, with the connective tissues, it's a genetic that we don't know yet. Because
migraines are genetic?
No, I'm just saying the tissues associated that I treat have to be genetic.
Oh, I see. Okay.
I say that because when I take that needle and go through that needle should be like a knife through butter. It should just glide. And what it isn't, what'll happen is that needle, when it goes through these tissues, it's like going through sheetrock, and it shouldn't. So as I'm cutting through these tissues, superficial to deep, using these solutions, as I'm slowly advancing, I'm blowing these tissue layers apart. It's when they heal and they become, completely viable again, and perfusion and it's separation, and it isn't like you got 5 layers of cardboard, then that's when you start seeing long-term results. And I will tell you, I have a migraine patient now. I've had her for 13 years. And when she first came in, she was high school. She couldn't get out of the basement. She couldn't finish high school. She had a boyfriend. They were, quote, going to get married. All that was on hold. Her primary called me up and said, I'm going to send this girl over, but she's a drug seeker. And so this 17-year-old kid comes into my office, and she gives me this great big brown box full of mostly pills that weren't even, they were full yet. And she goes, this is what I took. And I thought, she's not a drug seeker. Drug seekers don't bring this in. They don't present like this. And she goes, nobody's helped me. I've already been to like 7 specialists. I don't know how many neurologists. And she was suicidal.
That's sad.
I treated her on that day. It was the first day that she got relief. And then,
Wow.
long story short, now she's married, has a 4-year-old child. She comes in like every 2 weeks, like clockwork. I hit the same spots, and I'm convinced because hers only lasts 2 weeks, but it's the tissues. Because every time I hit every one of them, it's like they came back sick again. But as long as we keep those broke up and get some blood flow in there and the nerves can respond, she stays down to a minimum of maybe a 2 to a 3 at the very most.
You saved her life.
Yeah.
I said, you saved her life. Sounds like.
Well,
And
thank you, but I'll never take credit for that. But anyway, she's my miracle child, and not everything's 100%, but I can tell you with all of these folks, you have to start figuring out what part of the head and neck it's causing, whether it's a tension headache. And then another thing that happened to her too recently is that her primary said, well, so-and-so, we want you to go to this neurologist and you get Botox. So she did the Botox several months ago. And the Botox, they did like a crown of thorns around her. But honest to God, she got so sick, she got hospitalized. And all the Botox did in her condition, not other people, I'm just saying because of her genetics, it created all this scar tissue around her head. And it took me almost 3 weeks on a daily basis breaking up all this scar tissue that developed. And it has nothing to do with the provider, the skills, or anything they did. It just means that in this individual, this is what happened to her. But to reverse that, I had to go through and break all that back up again.
Well, and good thing you knew what to do, right? Like to be able to fix it, right? That's great that there was.
As I got into it and found the pattern, it took almost 3 weeks to break the pattern again. So we're back on 2 weeks again, or was on 2 weeks. For her, but a lot of folks that usually after a series like 3 to 5 weeks, they'll go a long time before they come back. And again, it's the same thing. Do these tissues develop superficially down deep in the anatomical areas that I'm talking about, that they're compressing on superficial nerves, that these nerves can't communicate with deeper nerves or the cranial nerves, meaning the 12 in the head and the face. And it's my observation that once you keep this stuff open and you get good blood flow, those nerves can fire and function like they're supposed to. They do fine.
Right.
So it sounds like it's hard for people to find doctors who are doing what you're doing and actually effectively treating these things. Are you going to write a book maybe when you retire? Like, are you going to spread this knowledge in a real way to other practices and whatnot?
Yeah.
I would love to, because I tell you what, before the good Lord takes me, it's like, why did he give me this gift, for 40 some years? I have trained a few people, but they kind of went to the wayside, so to speak. And I think a lot of it had to do because of reimbursement, is that they just could not make a living doing what I'm doing, because they have to fight insurance, or patients don't want to pay cash for it, that sort of thing. But yeah, the things that I've been gifted with, just like you're gifted with what you're doing right now, that's my purpose. I mean, that's why God put me here. And that purpose, I believe, it's supposed to be shared so other people can help others as well.
Yeah.
And I tell you what, there's no greater feeling. It's just like you with what you're doing. You get excited because you're changing people's lives by your podcast, because you're giving them hope. Am I right?
That's what we're hoping.
Yeah. This is why we exist. Yeah. We're here to bring people all of the good information to help them understand healthcare, right? Like somebody asked me that yesterday. They're like, what's your goal with the podcast? And I said to educate, create awareness, and inform, because knowledge is power. And this brings us joy. So much like what you do.
And if you write your book, I promise I'll read it, even if I don't understand half of it.
Well, I quit giving lectures because I said, just buy my tape, and if you have insomnia, you'll be asleep in 10 minutes.
We just have to have our medical dictionary next to us.
Hey, I'll audiobook the thing for you. I just want that knowledge to get out there. I have pain issues myself, and it sounds like you're a guy that, the world needs the knowledge from.
Yeah. And that you really understand like how to really treat people, because I keep thinking in my head as you've been talking, like we need more providers like you, because you've clearly helped solve so many people's problems where somebody else, they had no help. Like the story you just shared about that woman who's your patient. I mean, how awful for her to be one labeled the way that she was, and then to be like, I just need help, right? And this comes up a lot too in the show, is that we're trying to find the right people to help us solve our medical issues. And when you do, like, that provider it is, it's the hero, it's the hero in the story. So sounds like you've been playing a hero in a lot of people's stories. So
I would just like to be a humble guy. I'm not the brightest light bulb out there, but I do know the body well enough, and I've treated it from head to foot. I will tell you that if I had to give credit, there's over 100 scientists, physicians, or specialists that I had the privilege that they taught or trained or showed me something in my career to help me develop what I'm doing today. So I call it the platinum package, is that what they taught me has helped me to kind of put everything else together in what I'm doing today. So I'm not going to say, yeah, look what I did, look what I came up with. I'm saying I'm thankful that I had the people in my path that allowed me to do what I'm doing today.
I love that.
I do have another question. This is kind of coming back around to earlier in our conversation here, but you did say early on something about food having maybe something to do with the new, pain being a more common thing. Does diet come into your plans at all? Like, do you also use that as a tool on top of your actual needles and all these other treatments we've been talking about?
Only if the patients are open to it. Only if they're open to it. Because if they're not, it's like you don't want to go there, because you want to gain their trust. You want to be able to support them. But if it's something that they're not interested, or it may be that you're trying to tell them something that they don't want to hear, I don't want to lose them as a patient. So I just kind of ease into things and just see where they're at with it. If they do, we'll talk about it. Like, highly processed foods, obviously you can look anywhere in the literature, and that they'll cause inflammation in the body. And so everyone's on Advil or Tylenol or some NSAID of some sort or whatever. But, you are what you eat. And we didn't have this problem 50, 60 years ago. Mm-hmm. And all the sugar, everything that's in these foods is highly inflammatory. I mean, it is an issue. And some people maybe not, but others it can be. So in my practice, I just do the best I can with what I can and who I can. And I work with the individuals. And I hate the word patients. They're not clients. They're not patients. They're moms and dads. They're brothers. They're sisters. There's somebody to somebody. There's somebody special in somebody's life. And when I used to lecture years ago, people would get upset and say, well, you got to have boundaries. Well, I agree. You have to have boundaries. But you know what? We're all human beings. And you have to listen to their story. You have to understand what's going on in their life and try and put these pieces together. And what happens in my practice, nobody just comes in with one problem. For example, a young guy came in today, tennis elbow. It was more than tennis elbow. It was his whole arm. But then after I got done, he goes, oh, by the way, my orthopedist said that my C5, C6 is causing all these pains. Well, he didn't come in with that. He didn't even mention it. But as soon as his arm got done, his face lit up. And he says, can you fix this up here?
Can you fix me here and here? I got this.
And it's always more than one thing. So
yeah.
What I'm saying is that even like knees and stuff like that, what I do is that I, 1 out of 2, 50% of all knees, total knees, a year later, statistically still have knee pain of some sort. And my point is that the surgeons, they all do an excellent job. If there's no problem with what they did with the surgery, it's the structures that support around the knee where all the inflammation is left. So when you hit those targeted areas, you can get these people anywhere from 3 to maybe 6 months of relief before things start to come back again. So what I'm saying, I'm not knocking anybody because they're all good at what they do. They all trained hard. They all got to where they're doing because they know what they're doing. I'm just saying is that the things that are missing is what needs to be picked up, like on around joints and stuff like that.
Joint pain.
We're going to talk about shingles.
Yeah. Let's touch on shingles a little bit. I would like to hear about how you treat that, because that's a tough one.
It is. But if you get them in within the first 2 weeks, at least this is my hands. I'm only speaking for me, especially on this podcast. All these comments are mine only. I do not represent any pharmaceuticals or any entities or groups or companies or whatever. These are all my opinions, my observations, what I've seen. But with shingles, when those vessels pop up, the key is you take a small gauge needle again, like a 25, and that solution I was talking about, it's saline, lidocaine, and very small dose of steroid that you want to dilute so it's nanoparticles. You take that needle, you go under superficial and down towards the fascia, and you inject under these vesicles. And I can promise you, and I say promise, within 48 to 72 hours, if you catch them in that 2 weeks, they will shrivel up, dry up, and shrink. And within 2 weeks, there will be no scarring, and you'll have no idea that they ever had a blister. Now, another caveat with that, they need to be on the antiviral medications from their primaries, whether it's an NP, or their MDs or DOs. They need to get on their medications, but this will help resolve this, because what happens in shingles is that those blisters, what they do is they cause scarring, and that's to the dermis and those superficial nerves. So people that suffer what they call post-herpetic neuralgia, I mean, they're 6 weeks or, 6 weeks, 10 years, 20 years out. What you have to do on those folks is that you find the scarring. These folks, in my practice, take about 3 months. They have to come about twice a week because there's so much scarring. What you're doing is the same principle as I told you before. You take a needle with these fluids, you cut, blow up, and get rid of these adhesive barriers and allow that blood to come in. And these nerve structures will come back because it's all under the skin. So they're looking at what they call sodium channel drugs now. And your whole body, if you read that, they'll tell you in the current literature, we have 100% sodium channels, right? Well, pain is what they call sodium channels. So there's where the sodium chloride comes in, is because it is the electrolytes that are involved in these structures and cell structures that are lacking, because if there's no hydration, the nerves don't have the electrolytes to fire and pull through, and they don't have the blood flow. So what we're doing with these injections is not only blowing stuff up, but we're irrigating, just like in surgery. And in surgery, they irrigate with saline. So when you irrigate these tissues to clean out stuff and hydrate the tissues, and then it mingles with the blood, now the blood and the hydration, the nerves, if the tissue structures are open, can start firing again.
Do you find that people with shingles who end up in your care have been living with pain from shingles for a while? Like, I don't have like personal experience with going through it, but like you're on the antiviral, right? Like that seems to be like a pretty normal course of therapy, but then there's the pain that comes with it. Like, do you see a lot of people that have just kind of been dealing with it for a while and are finally like, oh my God, I can't take it anymore? And it's like, how long do people have it for typically?
Well, they can have it a lifetime. It's kind of a crapshoot in the sense that
I didn't know that.
People can get over it. I don't know what the percentage is. I don't think anyone can really say statistically how many people, get over their shingles. But I know that more than 50% of them, they're going to go on to post-herpetic neuralgia. And that means that whatever they had, that pain's going to be amplified. Then they put them on drugs like gabapentin and preganglion and those classification of drugs, which can help some, but they only reduce the pain by 1 or 2 points. But that's still better than nothing, because what else do they have? So what I'm concerned about with these new drugs, they're going to be good if you do not have the chronic chronicity that I'm talking about. If you have buildup of tissues, there's no way that medicine's ever going to get there. But if it's a majority of the patients that don't have it, that medicine will get delivered as they say it will. So you have to kind of pick and choose how this stuff is going to work and who it's going to work in.
Got it. Okay. Well, anyone?
Does that make sense?
Yeah, it does. And so I think
as much as we're the same, everybody's body is different, especially their brains, right?
Right. And I think it's important that people know, even like me, like I'm so glad that I know that if I ever get shingles, hopefully I don't, or if anyone I know does, that this is an option, right? Whether somebody tells you or not, it's something that, we should be aware that we have in our kind of healthcare tool belt, right? Like this is a way to treat it. So, because I would have never even thought about this, honestly. Like, I just didn't even have a clue that anyone would go to a pain management specialist for shingles. I just didn't know. So,
well, I don't know of anybody really doing what I'm doing with this because I scour the literature every night. And I'm not going to say I'm the author of this, but I think I'm pretty close to being the author of what I'm doing. But I can tell you is that my experience with shingle patients, like I said, if I get them in 2 weeks, it's like basketball. It's a slam dunk. It's 100%.
wow.
Nothing's supposed to be 100%. But if you get them in that 2 weeks, get them on the meds, you get this medication and you break stuff up. And think about it this way. What you're doing is you're increasing the blood flow to those blisters so that they evaporate and they can heal immediately. Otherwise, with the blisters, when they dry, they're scarring, and that cuts off the blood flow. That's where your pain is.
Okay.
And post-herpetic means you're scarred down. Wherever you had a blister, you're going to have pain.
Okay. I don't want shingles.
I feel like I understand pain much more than I did before already.
Yeah. I mean, just obviously shows up. I have my own issues, like Jeremy. I have nerve pain in my left arm because I have a spinal stenosis. So my nerve is compressed in my C7, my C8. Like I was going to acupuncture for a long time because I had nerve pain down my left arm. I have to have surgery. But now I'm thinking maybe there's another way, but I think I still need to have surgery because I have to create that space in the vertebrae in order for that nerve pain. And I haven't had it in a while, which is good. But when those flare-ups come and it lasted for months, it was awful. It was awful. I wish I had known.
You're making my back hurt right now.
This could have been a thing for me, maybe. So I'll know for next time. But
and everything isn't what it seems. You know, pictures are pictures, but I don't treat pictures. And and it almost sounds like heresy saying that, but I treat the symptoms. I treat what's going on, not the pictures. And I will tell you that it's just like surgery. 60% back and neck surgeries do fine. Another 20-some% don't do well at all, and another 15 or 20% go on to disability. So my point is, the surgeons are perfect. Meaning these guys, what they do, and gals, I should say both, they're specialists. So it isn't the surgery that went wrong so much as it is what is it that's missing. And I'm saying from you go out from the spine, it's the same thing that I talked to you about like an atlas. I can show you the nerve patterns like your neck, C5, 6, 7, everything that runs through your back, your neck, your shoulder, and your arm. And there can be 20 different isolated, what I call fuse boxes, that they are superficially entrapped. And as you treat them and have the patient go through like opening and closing the fist and watching muscle movements, things will change very rapidly. And even people that have positive EMGs, nerve damage in the arms or the legs, I can tell you, at least in my hands, that you'll find like whether it's a radial nerve, median nerve, or ulnar nerves, those are the three big nerves in the upper arm from the shoulder going down. So in the upper arm between the shoulder and the elbow, I will consistently find what I call 3 tracks that when I compress on them, it will paralyze the arm and the hand, and they can't move and say, oh my God, yes, that's where the pain is. And then there'll be 3 in the forearm. So there's a total of 6 for each nerve. And it depends on how many, maybe 1, 2, or 3. Usually it's only 1. But when I map that out and use that marker that I told you, the Sharpie, then what I do is I inject each one of those. And as I inject, I have the patient open and close their fist and tell me what's changing. And as I do each one, they will tell you exactly what's going on with their arm, shoulder, and neck, and saying, this is where I feel it, or now things are changing here. And in 5 minutes, that all changes. So these people that were told that I've got this permanent nerve injury and they can't pick up a cup of coffee, or that they need a major surgery, which they may, this is an alternative to that because it can help solve this stuff very quickly.
Good to know. All right. Well, I'm going to think of you when I decide to do something about this, which should be soon. It should be soon. So I'm looking at the clock. I want to make sure we start to wrap up here soon. But Michael, one of the things I want to make sure that we touch on, because you and I chatted about this earlier today, is this researcher in the pain management space who has the NIH grant that was cut, and kind of a little bit about that situation. Can you maybe shed some light on that, provide some insight, and first give us a little bit more context, because I'm sure my summary there was not very accurate.
Well, you were pretty close. I will tell you this. I just popped onto LinkedIn. I do every day just to see what's going on. And anyway, I can't remember his name, but he said that his 5-year grant got cut because of DEI, and that they didn't meet criteria, et cetera. And he'd been working a year with medications for trigeminal neuralgia. And that's about all I got. And then it went to something else then. So I apologize. But what I'm saying is that they're looking for a medication for trigeminal neuralgia. And I'm saying, well, that's nice. But if you think about how I'm treating, how is that pill going to change those tissues that are, in multiple areas? So it's like they can keep going that direction. It's like shingles. They're all looking for receptors under the skin. It may be the receptors, but remember this, it's also the scarring. So you may hit those receptors, but if the areas are scarred down, how can that change it? So I'm just saying it's difficult that a medication can get to the source that's supposed to, if they have the things that I'm talking about, if that makes sense.
The answer isn't always the pill, basically, is what,
The problem is blood flow.
And some people it may, but and many people it won't, is because if they have this involvement, how's it going to work? But if they don't, that may be a wonder drug.
Yeah. So maybe the solutions, like the work that you're doing, right? Like how you're treating trigeminal, oh my goodness, I need to say this, I need to read it, trigeminal neuralgia. Treating it, what you're doing is working. Whereas now, great that there is research being done for a pill, but like, is that really the right answer? Should there be more research in the space that you're doing?
I think both, and I think they can both work together.
Gotcha.
I think that there's a place for both, and it's like anything. It's like a marriage. Nobody's got the only solution, and that's where we all come in together, meaning pooling our resources. So yes, pharmaceuticals, I think, can play a role in what we do as well as I do. But we have to look at it differently. How are we trying to attack this and solve the same problem?
Yeah, they have their place, right? Yeah.
Yes.
Got it. Okay, good. I'm glad we touched on that too. And that you had brought that up earlier. And hey, we really looped this one back around to trigeminal neuralgia. I did read that literally.
Which is what brought us all here to begin.
Yeah.
Our patient case from yesterday.
I love it.
Gentleman, 59 years old. He had adrenal glands removed several months ago. And he's 6 feet 3 inches in height, 370 pounds in weight. He's a great, big fella. So the surgery they did with him, the position they put him in. Now remember, I'm an anesthetist. So when people are put to sleep, and it was a 7-hour operation, so he's contorted on this frame so that they can get to him, and so the muscles are paralyzed for 7 hours. And if you think about it, that your muscles can't move. So at the end, we reverse them with a reversal agent so that it's kind of almost like a whiplash to the muscles, because everything starts to contract again. But you got to remember, for 7 hours, this guy had all this compression in the pattern that when he woke up, he didn't have back pain before, but not only did he have back and hip and leg pain, but he had shooting pain and numbness down into the foot.
After the surgery?
Yes. It had nothing to, nobody's at fault. It has to do with just what happened with the positioning and the type of surgery. And the surgery was very successful. Everyone did their job. All I'm saying is a complication just due to positioning. And things can happen. But, the fact that this is a big man, all these tissues got stretched for 7 hours. So I saw him yesterday, and then he texted me today. He said, my doctor wants to know what you did today. And so I told him again, because the patients don't remember 5 minutes after they leave what you did anyway. So they texted back and said they really wanted to say thanks because of what just happened to me. So what I found on him is that as I treated the low back, his hip, I went down and followed the nerves that go down to that leg and the foot. And I did something like, I want to say 14 injections. I was done in 2.5 minutes. and that's all it takes.
You're fast. Wow.
Well, if you know what you're doing,
Yeah.
And I've done this. I've done probably over 750,000 injections.
That's insane. Oh, wow.
So what I'm saying is, if I train people, I can teach them how to do this stuff.
Uh-huh.
But honest to God, when he came in with a pain scale of 8, when he left, it was a 2. And he says, I can move my foot now. And he says, I don't have the tingling in my big toe. So
Wow.
otherwise, they would look at his spine and say, well, you got a problem at L4-5 or 5S1. And maybe this is a surgical consideration. And all I'm saying is that I followed what I found, and it had nothing to do with his spine.
Crazy.
Wild.
Yeah.
Well, he's lucky to have you. That's for sure.
He's tickle pink. He's going to come back one more time, and then he's done. But here's the guy. He's been suffering. He said, I can't even walk 10 feet, and I'm in pain. So, he's getting his life back. And I look at that. That was my purpose. My purpose was to help this man, so he could function again.
That's amazing. Well, what a great legacy that you have left. We're so glad that you have come on the show and shared all of your expertise and your magic. I think you're doing some pain medicine magic. And so grateful that Stacey and Tom was able to be treated by you, and Stacey shared her story with us. And just really appreciate you coming on the show and sharing. I was going to ask you, what's next in your career? I know you're about to retire. Maybe you're going to write a book.
He's going to write a book. He's got to write a book, right?
Yeah. I'm going to take a good 3 months off.
There you go.
Yeah.
Kind of my wife, my wonderful wife of 42 years, she's been waiting patiently for me to retire. She's got plenty of plans for us to do, but I know that I'm not completely done. In other words, like you said, I'll write a book or I'll do something.
Yeah.
But it has to be shared. It really does, because my goal before I leave this world is that universally around the globe, because I don't care if you're in China, Thailand, Russia, people suffer the same stuff.
Mhm.
And now that we have, instant communications, why can't this stuff be, brought across the world for other practitioners to help other people?
Yeah. Yep. Bring it on.
Yeah.
And I'm sticking to it.
I like
I
it.
love it.
That's great. Well, thank you so much for coming on the Uprising and sharing your amazing knowledge and expertise and that magic. You definitely have some. I'm sure you will be missed in the hands-on delivering care world. But yeah, bring us that book, and I think that you'll just keep living that legacy, right? Keep giving all this good stuff in chapter 2 or chapter 3 or whatever chapter this is for you.
I will. And I will definitely keep you folks posted. And believe me, it's an honor and a privilege to do this, is because if you can reach maybe millions of people with this podcast, I want them to know there is still hope out there, because people in chronic pain, their entire world, their life, socially, economically, psychologically, spiritually, it's like, when you go through the 5 phases of death, chronic pain is the same thing. They go through all the same phases, except they're not dead.
Yeah.
And the other thing is that these chronic pain patients, they know that if they talk too much, that nobody wants to be around them because they don't want to hear it. So the depression becomes even more so because they have to go inward to keep it to themselves. And then it's like, what am I here to live for? And the message I want to give them is that there is hope out there for you.
Hope.
Thank you.
Yeah, great.
And there you go, our conversation with pain specialist, or maybe I should call him a pain guru, Mr. Michael Perry. Amazingly informative and educational stuff there. Kind of blew my mind. But what are our main takeaways here, Heather?
Well, like I said in the show, I'm pretty sure he's just delivering magic. Pain management.
What's the old saying? A advanced enough technology is equivalent to magic. I'm paraphrasing a famous quote there.
That sounds good to me. Yeah, this guy is changing lives, saving lives, maybe. Although as humble as he came across, Michael Perry is the real deal. He knows that. I mean, the list of qualifications, his experience, the number of hours, the number of patients, the number of injections. It's like this guy knows
Like 750,000 injections or
it's
something.
something insane.
It's wild.
Like, I just can't even imagine when a patient comes in to his care and he looks at them and what he sees, like constellations of the body, like just probably like visualize in his head because of
Yeah.
how much work he's done in this space. And he is the person you want in your corner, if or someone like him, if you're dealing with any kind of chronic pain or any kind of acute pain that's come on, like what happened to Tom, Stacey's
And
husband.
I mean, he gave us a good few examples of people who were chasing some sort of relief for years, maybe,
Hmm.
and going to all these doctors and getting nothing really helpful from them. Then they walk into his office and he takes a needle to them for 3 minutes, and they're like noticeably better.
Yeah, that's pretty mind blowing.
That's pretty mind blowing. And why isn't this a common practice?
Yeah, I think that's probably what maybe was most surprising to me is that it seems the more standard, I'll call it, like the standard care approach is not to do what he's doing. So that makes him really special and unique. And to your point, why aren't more
Yeah,
people doing what he treating patients the way that he is? They need to be trained like
yeah.
under his or the book. He needs to write that book. So
And it's such a straightforward and simple logic that the pain is being caused by a lack of blood flow through these tissues.
mhm.
Uh, And they're trying to cure it with pills that rely on the blood flowing through these tissues to deliver the medicine
Yeah.
from the pill.
Yep.
It's inherently not going to work.
Right.
Like it's not going to work.
Yeah.
But that's all they're willing to do.
I
That's
now
crazy.
literally in my head right now. Do you remember that song you probably heard as kids? The knee bone's connected to the ankle bone or whatever it is. It's
Yeah,
like
the hip
every
bone's connected to the leg bone.
yeah,
and
I'm
all
like
that.
totally not singing this right. And no one wants to hear me sing either. But it is kind of that. Like that is like holistic care, right? That is looking at the whole patient, finding those underlying causes, right? Instead of treating the kind of obvious superficial thing,
Right.
instead you're literally, no pun intended, going deep, right? Injections, get
Yeah,
it?
yeah, the deep tissue.
I'm so funny. Thank
Merp.
you. I'll be here all night. Don't forget to tip your bartender. So, it's just like you got to go deeper, and good doctors, good providers, good medical professionals do that.
Right.
So,
They look at the whole picture, not just this one symptom at a time.
yeah. Yeah. I think him retiring,
Sad.
that's going to be a big loss to Omaha and,
I-
and all the people that he's created or
I
treated.
will narrate the audiobook if he writes it.
You should offer your
How's
third.
that for a deal? I'm in, dude. You write it, I'll read it.
There you go.
I will read that into a microphone for you.
Yeah. Also too, like before we'd like close out here, pain is a common problem that manifests and shows up in a lot of different ways for different people, whether it's shingles, whether it's migraines, whether it's low back pain, whether it's uh, trigeminal neuralgia, or
Got it.
everything in between. That it's common, right? And
Yeah.
so I think understanding what your options are, as a patient, and to know that it doesn't just stop with pharmaceuticals. They certainly play a role. Um, there are people like him doing really, really great work with patients and saving their lives
Yeah, and hopefully it becomes,
or improving them.
hopefully he can get it out there so that it does start working its way into the mainstream, and maybe the whole concept of pain management can change for the better.
Yeah, I hope so. Anyway,
And that's why we call it an uprising.
Yep.
And
It is.
if you appreciate what we're doing here on the Uprising, make sure to click all those happy little fun buttons, whatever platform you're on before you go. The likes and subscribes, maybe share it with a friend. Rating and review is always a great donation of a couple minutes of your time towards the cause here. Let us know how we're doing. We are on all the major listening platforms. We are on YouTube. We have a Patreon for as little as $1 a month if you want to get into the monetary support of the Uprising. But best thing you can do is just keep listening, man, because people need to hear what we're talking about. But where else can they find us, Heather?
So you can find us online at healthcareuprising.com, but also out on all the social media platforms. We're on LinkedIn, Instagram, Facebook, and Blue Sky. Post out there all the time whenever our new episodes drop. Although if you just set that auto download, you just get those
That
things
is the
showing up.
easiest way. You never miss a beat.
That's right. Otherwise, look for our posts talking about what we've got coming. We also share a lot of posts from the people that we interview, so you can stay educated and informed. We're a great spot to learn about all sorts of new things. Also, we're always looking for people to bring on the show, whether you're a startup founder, you represent a young company doing something really innovative and smart in the healthcare space. We'd love to have you on. Also, our human stories are a really important part of our show. So if you've got a sad, positive, happy, whatever, in between, all the things, story from your own healthcare experience and you want to talk about it, we'd love to have you on. So whoever you are, email us at healthcareuprising@gmail.com and we'll get connected with you and go from there. So with that, keep looking for the good in the world. It's sometimes where you least expect it.
This has been a Shut Up production.